final episode of our Patient Rights series. We're talking about the patient's right to choose medications, equipment, and who makes visits in the home. You're listening to Heartbeat from the Heart of Hospice. I'm Jerry Fenter, here with Helen Bauer.
Whether you're a family caregiver or an end-of-life professional, we're here to enhance your hospice experience by connecting you with information you can use about end-of-life care. Because we know how busy life can get, Heartbeat is designed to give you helpful information in a bite-sized format.
Today's episode is sponsored by the Love Always Project. The team at Love Always understands that while loss is a natural part of life, it's a topic that a lot of people would rather just not think about. On the Love Always Project website, you'll find support related to grief, loss, and bereavement, as well as funeral pre-planning. With all the overwhelm that comes with the loss of someone you love, it's great to have the resources the Love Always Project provides. Check out their website at lovealwaysproject.org. Okay, so this is the last of our series on patient rights, and we have talked about so far, let's see if I can remember all of these.
Close your eyes and do it.
No, I can't do it. So we talked about the patient's right to voice any concerns, in other words, to make a complaint.
Right.
And to not have any discrimination for doing so, not to be mistreated or neglected or anything else because they did make a complaint.
We talked about the patient's right to choose a physician. We talked about the patient's right to stop and start hospice.
Right. And today we're going to talk about the patient's right to choose their care plan.
What is on the plan of care?
Right. Exactly. So, well, first of all, why don't we describe what exactly is a plan of care?
A plan of care is a plan developed by the interdisciplinary team in collaboration and cooperation with the patient and the responsible caregivers and or facility staff that includes problems, goals, interventions, and outcomes.
Oh, spoken like a true regulation and compliance specialist.
I know it. That was a thing of beauty.
You did that so
That was
smoothly.
awesome. Basically, what it is a plan for the patient's care that addresses body, mind, spirit. It includes all the interventions that are needed to manage what's going on with that patient. Okay. So anything that the chaplain, aide, nurse, volunteer coordinator, music therapist, social worker, anything that anybody does should be on that plan of care.
Right. Let's get down to a few specifics here. So It includes things like DME, which stands for Durable Medical Equipment. What do they need when it comes to medical equipment? Do they need a bedside table? Do they need a bedside commode?
Right.
Do they need a bed?
Oxygen.
A
suction machine, a wheelchair, a shower bench, all of those things like that.
Okay. And of course, medications. What kind of medicines do they need?
Right. Those are also part of the plan of care. And who's going to administer them and when, who's going to pay for them, et cetera.
When it comes to the other disciplines, like social worker and chaplain, they're going to talk about things that deal with finances, things that deal with the spiritual side.
Advanced care planning.
Advanced care planning is a big one too.
And the aide is on there as well. The aide interventions, how he or she helps with personal care, standby assist for a shower, bed bath, all of those interventions, possible interventions, are customized, individualized for a particular patient, and that's what's included on the plan of care. There's a whole lot that goes into it. It's a very detailed thing if it's done well and done correctly, but yes, all of that. So we're going to be focusing on the durable medical equipment, the medications, and what disciplines are making visits.
Okay, so let's talk about some of these then. Let's begin with medications. So doctors won't order meds, first of all, that are contraindicated.
Right.
Why don't you, as a good nurse, explain that?
Contraindicated means they're not going to be beneficial for the patient, or they could possibly be harmful, or they shouldn't be given together. Things that are really not indicated to be in the best interest of the patient's care.
Okay, but the patient doesn't have to take everything that's offered.
That's true. Some patients may choose not to take, here's a big one, morphine.
Right.
A lot of patients will be fearful of morphine, the effects of it. Caregivers can be concerned that it will accelerate the death or precipitate out the death.
Which it doesn't, but there's a fear there.
Right? That's a whole nother podcast, but yes. Or cultural beliefs may dictate that the patient has to go through suffering. It's considered cleansing or part of the human experience. Just depends. There are a lot of different reasons a patient may refuse a certain medication.
One thing to keep in mind, too, is that the agency also will decide what it will and won't pay for.
Yes.
How do they decide that?
That isn't that a question? There are a lot of different ways, a lot of different criteria that an agency uses to decide whether it'll pay for a medicine. First of all, is it related to the patient's terminal condition? We used to say just terminal diagnosis, but it's broader than that because we talk about symptom management. Anything related to pain, shortness of breath, nausea, diarrhea, anxiety, agitation, delirium, anxiety. I think maybe I said that one twice. Anything like that. Those medications should always be covered. Anything that's considered symptom management and anything related to the patient's terminal diagnosis, terminal prognosis, related conditions, those medications should be covered. However, it is always up to the discretion of the agency. There are some medications that are just cost prohibitive, and they will have conversations with the patient and the family about A, whether they're going to pay for it, and B, whether the family wants to continue that particular medication.
Right. And so the agency is required to tell the family, the unit of care, what they will and won't pay for.
Absolutely. Absolutely. That should be very clear within a few days of admission.
Right. And so that, again, is another whole podcast series to go over those kind of things. So let's talk about the DME, the durable medical equipment.
Got it.
Patients get to choose what equipment is needed and what the agency is willing to furnish.
Right. So we talked about it like Luby's. You go to the Luby's cafeteria and you can choose what you want, pick and choose what you want, but only out of what's offered.
Right, exactly. So
you have to order off the menu, in other words.
Right. You can't go to Luby's and expect them to serve you a big 16-ounce sirloin steak.
Exactly. You can't go in and say, I need you to make my grandma's macaroni and cheese.
Yeah, right. Yeah, it's not going to happen.
Right. So they get to decide. Typically what a hospice agency does is they have a contract with a DME company, an equipment company, and they have a list. It's a short list, and it's the basics: hospital bed, wheelchair, walker, shower bench, bedside table, bedside commode, oxygen, suction machine, things like that. Those are the basics, and a patient may not need all of those things, but they could choose off of that list. A nurse would select what's appropriate for that patient. And if there's anything special that a patient might need, like a Broda chair or a high-backed wheelchair, then that's an additional negotiation between the DME company and the hospice agency. But a patient can say, no, I don't want a hospital bed. They can choose not to have that part of the plan of care. And the reason I bring that up is because hospital beds seem to have a significant meaning for patients. You know, it's a sign of illness. You're taken out of the bed. That's a very intimate space, right? Your own bedroom and your bed. But it isolates you from your sleeping partners. If you've had a spouse or a partner for a long time, it immediately puts you in a different sleeping space by yourself. And also, those beds are very large, and typically, for a lot of folks, their homes won't accommodate them in a bedroom, so that hospital bed's placed in a common area of the house.
Right. So they might want to decline getting a hospital bed, or at least delay getting a hospital bed until it becomes absolutely necessary.
Right. Oxygen is a little bit the same way. You know, an oxygen concentrator is a big, boxy piece of equipment, and you've got the tubing that can snake around and get under everybody's feet. But patients may even exhibit shortness of breath when you're looking at them, talking to them, and they may still tell you, I don't feel short of breath and I don't want oxygen here at home.
And again, this is the patient's right to choose what equipment they want and what they don't want. Hey, this is Jerry and Helen from the Heart of Hospice. We're about to start Season 7 of the podcast, and we want to let you know there are some changes coming. First, the weekly Heartbeat episodes will be temporarily suspended.
That makes me sad.
I know.
But we will be publishing our longer episodes featuring industry experts every week beginning August 5th. You can be on the lookout for some fantastic guests and great topics. For instance, Rabbi Steve Leader will be with us to talk about how the death of his father changed his views on death and dying. And our friend, end-of-life educator Carol Schoenberg, will be with us discussing anticipatory grief.
Yes, and Jill Johnson-Young is back. She's going to discuss physical intimacy during serious illness and end of life. Author Anita Hannig will be talking with us about her new book on medical aid in dying. And board-certified hospice chaplain John Prescott talks with us about Zen Buddhist practices around death and dying. So be sure to hit the subscribe button on your favorite podcast platform so you don't miss a single episode.
The Love Always Project is a grassroots movement created to encourage people to pre-plan and pay for their funeral as the ultimate act of love for those they will leave behind. Many people don't know they can plan their funeral in advance, but most people who do know they can pre-plan simply choose not to act on the opportunity. The Love Always Project knows there are benefits to completing funeral pre-planning, such as minimizing pain for your loved ones during what can be a difficult time of grief and mourning, and leaving a final connection with those you love that can mean so much. By promoting discussion about end-of-life issues and providing expert information, Love Always helps people design a better farewell. Funeral pre-planning and funding can reduce financial and emotional stress on your loved ones, giving them time to grieve and giving you peace of mind knowing your wishes will be carried out. Follow the Love Always Project on Facebook and Instagram, and check out the Love Always Project forum page to find a space to share and learn about the many aspects of end-of-life issues. Visit lovealwaysproject.org to find the support and resources for funeral pre-planning you need. Now on to today's episode.
Let's go on to another topic, and that is the team visits.
Yes.
Who can visit, and who does the patient want to visit? Well,
The nurse can visit. The nurse can visit
here's what we know.
everybody.
Here's what we know. The nurse has to visit everybody. They can't decline the nurse. That's just,
Did you just say they can?
They can't. They cannot.
What happens if you refuse to have the nursing visit? What happens?
Well, if you refuse too many times, you eventually get discharged off service.
You get discharged off hospice, right? Because we can't meet our regulatory and compliance, our assessment requirements.
That's true. So there are other members of the IDT, the interdisciplinary team, that they can be refused, okay?
I feel so sorry for you.
Stop it.
Okay, so our CNAs, our wonderful aides, they work so hard. They're the workhorses of the interdisciplinary team. They see our patients more frequently, more intimately, and they do amazing work. However, patients at the start of care with us in hospice may not want or need an aide right away.
Right, and they may not want them for privacy reasons because they just want to preserve their privacy, their modesty. They may not want them because for them it feels like it's taking away their independence.
Yes.
There's still some things that they can do for themselves, and they still want to do those things.
Right. Dignity, that it takes away dignity to have somebody help you bathe. However, we will also say that patients sometimes have a limited awareness of their own abilities or what's really considered safe because in the past they have functioned what they consider just fine without having an assist for their personal care. So it is their choice whether to have the aid or not.
Okay, so what about social workers?
These are our problem solvers. I love the social workers.
They are, but they're problem solvers because they often will have to dig in to personal information and financial information, but they can solve a lot of problems when they do that. But sometimes the patient and the family don't like it when they start asking questions.
It can be perceived as intrusive, They just want to know about my money. And there also may be some misconception about what the social worker does with that information. You're just going to tell the government how much money I have. Well, of course, we don't do that.
No.
That is not what the social worker does. But the patient has the right to refuse if they don't feel that the services of the social worker are appropriate for them.
Right. And then there's the chaplain.
Everybody likes to refuse the chaplain. My goodness.
This happens quite frequently, I have to say, because let's be honest, the chaplain sometimes is seen as intimidating, threatening, unfamiliar, and the patient may refuse a chaplain because they have their own clergy
Sure.
that makes visits, which is fine. But here's what I will tell you. I'm just going to throw this out there. Your clergy is not an end-of-life specialist like a chaplain is.
Right.
So a chaplain who is a hospice chaplain is trained in end-of-life care. Your pastor, clergy, imam, whomever your faith leader is not always trained in end-of-life care. And so just something to consider.
And they can certainly work in conjunction. So say you do have a community clergy person coming to see you. You have your priest, your monk, whoever you work with in your faith community comes to your house to check on you and your family. There isn't anything that says your chaplain can't also come.
Right.
Right? I think the biggest reason we see people refuse visits from the chaplain or spiritual counselor is because they just don't know exactly what the role of that chaplain is.
And they're concerned that the chaplain may come in with his own agenda.
Exactly.
Okay, so before we talk about the nurse, let's talk about volunteers.
Fine.
So volunteers are also a set of disciplines that can be refused.
Yes.
Now, volunteers are a really great addition to the member of the team, and it helps to have those people there, but it's optional.
They are the cream of the crop.
Oh, yes.
They're not going to stick you with a needle or give you any medicines. They're not going to ask about your finances or your faith. They're not going to ask you, can they give you a bath and take your clothes off and make you cold? They're just there for whatever you might need.
Right. Now, keep in mind, they might not be available in some rural areas where there's just not enough people to go around.
Right.
But you can always ask and see. But volunteers they're always going to be offered. They can be declined, however.
Yes. So we will say that a lot of agencies have struggled with their volunteer programs during the pandemic, right? Volunteer programs basically had to be shut down. Our requirement to use volunteers has been waived. It still is. We're in early 2022. That requirement is waived at the moment. So a lot of agencies are basically rebuilding their volunteer programs, but it's still the right of the patient. It's a beautiful service and a wonderful connection if a patient and caregiver are willing to have them in there, but they can refuse them if they want to.
Right. Okay, so finally, let's talk about the nurse. I think we talked about the nurse already, haven't we?
What? Let's talk about them again.
Okay. So,
nurses are awesome. We work so hard. Is that what we're talking about? How wonderful nurses are?
I don't think that was the point, but yes, they are. We recognize that. Here's what we have to tell you, though. The patient must be seen by the nurse at least every 2 weeks.
Yes.
Okay, so
yes,
that's a requirement, is that an RN has to see the patient every 2 weeks.
At least every 2 weeks.
Right, at least every 2 weeks. And refusing a nurse visit will cause the patient to be discharged off service.
Not just one, right? You might have a bad week, bad day where you refuse one visit, but a pattern that's habitual where they really cannot provide your care.
Right.
No.
Because here's what happens. The nurse can't do an assessment without actually seeing the patient. And without an assessment, a lot of things can't happen.
Right. We have to have what they call a comprehensive assessment, right? That's part of regulation, part of what we do. So without that, patient has a right to embrace all of those things. Maybe that's the way we should say it.
That's good.
Instead of the patient has the right to refuse, the patient has a right to embrace and welcome all the different disciplines and enjoy all the different aspects and continuum of what the skills of a hospice interdisciplinary team have.
Right. Here's the beauty of hospice. All these things are available to the patients and the families.
Right.
They're there. They're available to you. But if you don't want them, you don't have to have them either.
Right.
It's your choice.
And you can always say, not right now. And then down the road say, yes, I think we need this. I would love for the social worker to come here because I'm ready to sign a DNR. I'm ready to discuss the guilt that I feel or the concern that I have about an afterlife. I want to talk to the chaplain.
Right.
Or I'm no longer steady on my feet and I need to sit down the whole time I'm taking a bath. I need an aide out there. Or the caregiver's gotten isolated and says, I would love to have a volunteer. We need some companionship out here.
So all these things are available, and the patient has the right to embrace or to decline.
Yes.
Either way. Okay, so this is the end of our series on patient rights. We hope that this has been really informative and has helped you to kind of clear up some things in your head about what you can and can't do with hospice as a patient or a family member. But we hope that it's really been beneficial for you. And if you have other questions about this, please reach out to us. Send us an email at host@theheartofhospice.com. We would love to answer any questions that you have.
Thanks for listening to Heartbeat from the Heart of Hospice. I'm Helen Bauer here with Jerry Fenter. Because we know your hospice journey is 24/7, you can always find us at theheartofhospice.com. Subscribe to the podcast wherever you're listening, and please take a minute to leave a rating or a review on Apple Podcasts.
To connect with us, you can send us an email to host@theheartofhospice.com. You can also find us on social media. And remember, no matter who you are, or where you are in your hospice journey, you are the heart of hospice.